Another special view that we're going to have for the shoulder is going to be an axillary view. So this view is going to be a view very similar to the axial lateral view that we took of the hip. So basically we place that arm, again, externally rotated, abduction, but we don't shoot an AP, we shoot from inferior lateral to superior medial. So definitely know where your x-ray beam is coming from and where it's going to. Now, as you can see, axillary view gives us a much different perspective. That coral cord process shows right up, not a whole lot of other structures attenuating or obscuring our view. We can still see a little bit of the acromion. We can still see the glenoid. And we get a much different view here as opposed to the other views that we saw. This is another view of the scapula. This is called the Y position. The reason it's called the Y position is because if you think about it, when they shoot the x-ray beam in, and they're going to shoot it from the opposite side of the body, the patient is placed at about a 60-degree angle to where the x-ray is being shot from. And what it does is gives us a view of the scapula that makes the scapula look like a Y. And we'll see that in the next slide. So there's my Y view. So again, I can still get a lot of structures viewed here. I can still see a lot of different things. So I get a pretty good idea of what's happening at the acromion, pretty good idea what's happening coral cord process and clavicle as well. All right, so let's get into some shoulder injuries. These get a little fun. Obviously, what we're looking at on both these pictures, these are some examples of some shoulder injuries you're going to see. I will tell you that in the clinic, a lot of times you're going to have patients, especially that our patients are coming to us quicker and sicker than what they ever have, that we're definitely going to see some shoulder injuries, and we have to be very proactive with communicating to other providers about imaging and other interventions if necessary. So when we look at radiologic assessment of trauma, when we're looking at radiographs, obviously the best thing radiograph does is show you bone. So fractures, dislocations, again, we're going to go through our ABCs there. CT, if it's something complex or we're trying to figure out where the fracture fragments or segments have gone, then CT scan can be very beneficial. MRI is going to be more of our soft tissue cartilage injuries. I'm sure that you guys are very familiar with these with patients that have things like rotator cuff tears or they have, a labrum tear. Those are going to be soft tissue injuries. Now, looking at clavicle injuries and specifically the acromioclavicular joint, we're going to have some fractures. Now, the clavicle is a pretty easy bone. We're either going to have a fracture at the proximal third, middle third, or distal third. And then obviously we're going to have a acromioclavicular joint that's going to attach our acromion to the clavicle on top of a sternoclavicular joint as well. So in looking at these images, what we're going to see here, look at the very top image, this is obviously going to be a radiograph. So what we see is that the clavicle and the acromion do not have any sort of continuity. That AC joint has been, AC ligament has been ruptured. The clavicle then has ridden superiorly. Be really, really careful when either there's an acute trauma. So what we consider acute is going to be within 2 months of the injury, so 8 weeks, 8 to 9 weeks. And watch out for weightlifters with this one. There are a lot of folks that really, really, really push the envelope when it comes to overhead presses. That's actually how I tore mine. So I have a grade 1 AC sprain on my right side. So I did it pushing overhead press. A lot of folks will push it with push-ups and bench press and things like that as well. On an x-ray, what we're going to see is we're going to see a loss of the normal cortical line. So think back to the ABCs. Our A is not correct. We don't have correct alignment. MRI, we're looking at a high signal at the distal clavicle. So what we can see here is we see a lot of lightness, a lot of white right at that AC joint, showing there's been disruption in the tissue. And on the bottom, we're looking at a different MRI here. So the acromion is normal, but now we see an abnormality isolated to the distal clavicle. So we don't see the actual AC ligament disrupted. What we actually see is a clavicular injury. Again, very different picture, but very good to know the differences between these. So this is another one. This one is a really super easy one. What I want you to do is I want you to pause the slide and I want you to go through the entire radiographic features of fracture. So I want you to look at this and I want you to understand not only do we have displacement here, but we also have a lot of other things happening as well. So I want you to be able to identify and describe how that fracture is. So looking here, not only do we have a clavicle fracture, but we also have a separated shoulder as well. So obviously what we see is we see a lot of gapping, for lack of a better term, at the AC joint. And then we have a clavicular fracture happening on top of that. Very, very common, especially with things like falling on outstretched arms and other sorts of trauma. Now looking at more of an anatomical view, be very familiar and very confident with describing the differences between the acromioclavicular ligament, corticoclavicular ligament, and the coracoacromial ligaments. So make sure that we know the differences between those. So looking at Hill-Sachs lesions versus Descartes lesions, we're going to kind of identify what the differences are and how the differences look on plain film radiograph as well as some other imaging modalities. So what we're looking at here is we're looking at the difference between what's an avulsion fracture and what's going to be a soft tissue injury. So what you see on the picture on the left hand side is a soft tissue injury. Okay, that glenoid has been pulled away from the glenoid fossa, or sorry, the labrum has been pulled away from the glenoid fossa. And this is exactly how it's going to look on an axial MRI. Very different picture when we look at a Bankart fracture. So a Bankart fracture is going to be an avulsion fracture of the glenoid fossa. What you can see is that the labrum has been pulled away along with a little bit of bone. And then obviously what you can see on the axial MRI is that it looks very, very different from the previous picture we saw. So taking a look at this radiograph, you can definitely see in the inferior aspect of the glenoid fossa that we do have an avulsion fracture here. So this would be classified as a Bankart fracture. So taking a look at this picture, this is going to be a glenoid labrum tear. And the reason we know this is a glenoid labrum tear versus a Bankart tear is take a look at the glenoid fossa. That glenoid fossa is pretty much intact, and we really need to be discriminative when it comes to these sorts of injuries. So here's a Bankart fracture on CT scan. What we have here is we have three different views. Obviously the view in the upper left hand corner in the middle is going to be more of an axial CT, so you get a really good idea how that picture is going to look. And then the lower right hand corner is more of a 3D computerized rendering. This is an even better picture. So what we have here is we have a Bankart fracture again. Obviously you can definitely see the detail. This can become very crucial information to know, because if we are a surgeon who needs to go in and know what procedure we need to do exactly, this is probably going to give you one of the best images that you can ask for without actually going in through an invasive procedure like a surgery. So moving on to MRIs, these are three different MRIs. What we really need to know with MRI is that this is how we're going to view the majority of the soft tissue in and around the shoulder joint. MRI is very effective for viewing those sorts of structures, but we have to know definitely when to use it appropriately. So back to the basics with MRI. T1 weighted is going to be most of our anatomical view. What we have to understand is that free fluid is going to have a low signal intensity. That's very important to know, but tendon and ligament is going to be dark. T2, however, tendon and ligament is still dark, so both on a T1 image and a T2 image, those are both going to be dark. But definitely understand where we're going to use both of those. T1 is going to be more the anatomic view. T2 is going to be the view that we're going to see clinically in the majority of cases, because that's going to be more of the pathologic view. So definitely go back to ACR criteria, definitely go back to Riemann for that decision-making process. So here's a coronal MRI. So this, take a look at the upper right hand corner. This is going to give you an idea of where exactly this MRI is being shot, if you will. So definitely be familiar with the structures that we're going to see on a coronal view, and you can definitely see a lot of the detail. You can really see that supraspinatus versus the deltoid. You can really get a good idea of the amount of detail we can see with a coronal view of an MRI. So taking a look at the anatomy, make sure you're familiar with the anatomy that we can see in each of these views. So my suggestion is definitely try to blind the answers and try to pick out and identify these. Like I said, we're going to do some more Blackboard Collaborate sessions where we're going to do a lot of labeling, and I want to make sure that you guys are very familiar and comfortable with how to label an MRI. So give this a second. This is going to unblind you from some of the answers. So, but again, make sure we know what a shoulder coronal view is going to look like. We're going to look at some other views as well that MRI is going to be able to afford us. Definitely be able to identify each of these structures. Definitely be able to look at each of these structures and understand not only how it's going to look normally, but then how is it going to look when we're dealing with more of a shoulder pathology. This is more of an axial view, much different representation and obviously much different picture that we can see. So be familiar with the anterior portion of the shoulder versus the posterior portion. That typically is the spot that trips people up, and definitely be very familiar with the anatomical structures that we're going to see with each of these views.